Welcome to your online mandatory resuscitation training, your medical emergency training. We've had to change how we deliver our education in light of the current COVID crisis. So what we would like you to do is enjoy this presentation, take what you can from it in terms of learning points, and we'll expect you to answer a little questionnaire at the end of it. And you need to do this before you come to us for a practical session. So once you've completed this online section, we will see you in the resuscitation training room to make sure that you've got the practical resuscitation skills that you need for the next 12 months. My name is Pat, I'm the lead for resuscitation here at Poole, and also delivering this training session will be Dave and Ingrid, and you'll get to hear and see them shortly within this presentation. Okay, so what we're going to discuss is the chain of survival. We talk about this every time you come to training with us, and it's the Resuscitation Council's logo, and they like to use this logo because the chain is only as strong as its weakest link. So there are 4 elements in the chain of survival, and we're going to talk a little bit about each of those. There'll be some focus on the initial link, which is early deterioration in patients, and recognising that quickly, because that's when we can really make a difference. At the point at which a patient deteriorates, we can either decide to intervene and escalate them fully into critical care, or we can make decisions that actually they're reaching the end of their life, and it may be appropriate to limit the care and treatment that we give them and make them comfortable towards the end of their life. So calling for help early is always really important. We're going to talk a bit about that. The second link is early CPR. This is your chest compressions, and there have been some changes in what we need to do in terms of resuscitation in light of the guidelines related to COVID. So we're going to present the resuscitation to you in that sense. The biggest risk to us is through aerosol generating procedures, so we need to be very mindful of our own safety when dealing with a collapsed patient, and we should really be in PPE, and we will talk about that more as we go through. Early defibrillation is still a very key treatment in resuscitation. We know that defibrillation works for some patients, and defibrillators should be applied to all patients in cardiac arrest. If they're shockable, the gold standard for delivering that shock is within 3 minutes of collapse or 3 minutes of cardiac arrest. So again, it's very important that we get that early call for help out and a team with the skill to defibrillate are on their way to you. If you have an ILS or ALS certificate, then feel free to defibrillate. Obviously you've had that training. And that's something that we can deliver to any patient in cardiac arrest, COVID positive or negative. Post-resuscitation care, that would be where we're talking about moving that patient into a critical care environment for ongoing organ support. This is a really important and sometimes neglected link in the chain of survival. And we have to consider if our patients have treatment escalation plans that state they would not be for escalation to critical care, then actually is the rest of the chain of survival appropriate for that patient? Because if we don't give them that good ongoing organ support, their chance of a good outcome and a discharge home with a good quality of life are greatly reduced. So we need to consider whether CPR is appropriate in those patients that would be for ward-based care only. And that's a good time to start thinking about making DNACPR decisions. And we'll talk a bit about that at the end. So in terms of what happens here at Poole Hospital, we want to just show you our statistics. And this is a slide I'm really quite proud of. Particularly in the sense of the cardiac arrest data, because we've got an ongoing trend of a reduction in cardiac arrests. And this is despite the fact that we believe our patients are generally sicker than they have been in the past few years. So this is all a testament to the fact that we do have a really good system for early detection. That's our news system. We have a good response team. That's our news team and our medical emergency team. And we have really good decision making with regards to treatment escalation and DNACPR decision making. And also it's to the care the patients receive on the wards. It is that early recognition and that good input at an early stage. So that's always a reassuring thing, and our aim is to keep those cardiac arrest figures as low as they are now. So in the last year we had 56 arrests in our whole hospital, and I think that's a really low number. But it also means it's something we don't see that often, so it makes training much more important because we're not exposed to cardiac arrests on a regular basis. The non-arrest medical emergency calls, you can see they're going up. And again, that's a fairly positive figure because it means that we are recognising that deterioration and we're not afraid to put out that shout for help. And that's what we always want. We want staff to feel confident that if they have concerns about a patient, they can pick up the phone, call the team, and the team will respond. So last year there were 407 times the team responded to people that were either collapsed, having a seizure, having some chest pain, looking acutely unwell, maybe anaphylaxis. Those are the kind of things that would generally trigger a non-arrest medical emergency call. The news calls are fairly static over the past few years, but what we can say is since the introduction of News 2, there has been a fairly significant rise in the number of news calls because we dropped the trigger score from 9 to 7. News calls we will talk about in a little bit more detail later. But again, the fact that we have so many of those, that's the majority of our emergency calls, is recognition that we have that group of deteriorating patients out there on the wards. The next slide is looking at the outcomes from cardiac arrests. Now, the national average is reported at being 18 to 22% survival to discharge from in-hospital events. So we had a rather good year in 2019 with 27% of our patients that had a cardiac arrest of surviving to discharge. That's 27% of those 56 patients we mentioned before. About half the patients survived the cardiac arrest, and by definition that means their heart restarted for about 20 minutes, but they did not survive to discharge from hospital. So the green figures, the survive to discharge, are probably the most important figures on that slide. And again, it's about appropriate selection of those patients where resuscitation will be of good benefit. And I think our 27% reflects that. So if we're shouting for help, we know that the emergency number within the hospital is 2222. If you call that number, switchboard will answer usually very, very quickly indeed. And the information that you need to give to switchboard is which team you would like and where you want that team to go. And it's important to be very clear in your instructions. So you will want the adult medical emergency team, and if you can give your ward and a bed space number, even better, the team will come to you as quickly as possible. If you're in a non-clinical area or happen to be away from an internal phone, there is a way of activating the MET team from a mobile phone. So you would dial the pool area code of 01202, and then 44 gets you through to the hospital switchboard, and then you do your 2222. So you can pop your phone onto speaker, and you can manage your patient, and you can be activating the medical emergency team at the same time. Some areas of the hospital may also need a 999 call. So if we have a collapse in the car park, for example, it may be difficult to extricate that person with our lifts don't take trolleys, and we might need our paramedics to support us with the removal of a patient to a place of safety such as the emergency department. There are plenty of medical emergency teams and about 16 teams that we actually can activate on 2222. So again, it's really important that you tell switchboard who you want. So in the purposes of medical emergencies, we have the adult team, the paediatric team, the trauma team, obstetric team, and the neonatal team. Stroke pre-alerts, major hemorrhage protocol, security fire, all of those things are also activated on 2222. So please be very specific to switchboard, the adult medical emergency team, please. When the MET team arrive, they will come to you within 2 minutes, hopefully. It is a running response, and you will usually have at least 9 people that will respond to that adult medical emergency call. One of the ways of determining whether you might need a medical emergency or a news call would be whether this patient has airway or breathing difficulties. So if they have airway or breathing difficulties or are unconscious, then the call of choice should be the adult medical emergency team, because that team contains anaesthetic staff. So we at the moment have 2 anaesthetists, although that may well change to 1 in the near future. The team leader on both the MET team and the news team is the medical registrar on call for that day, and he or she will be supported by the junior medical doctors, the SHO and the house officer. You also get the clinical practitioners on for outreach, and a porter and the resuscitation team coming to the MET call during daytime hours. The news team is a slightly smaller team, and they're responding to patients who meet the critical risk criteria in a ward-based environment. Again, the same medical registrar will respond to that team along with the junior support and an outreach nurse, and that is a 5-minute response time. If you work in a department and you have a patient that needs help, the call should be medical emergency, not news. The only areas of the hospital grounds or site that we don't cover as a team are Parkstone House, which is the accommodation block, and that's because the majority of people in that building are nothing to do with Poole Hospital, so that is a 999 call, and also Forest Home, because again that's away and out of our remit really, so if something happens over in Forest Home, that would be a 999 call there too. But remember, from Forest Home, from an internal phone, you'd have to dial 4 9s to get your outside line first. So just to update you if you're not aware, the National Early Warning Score changed last year, that it was a mandate from NHS England that News 2 would be used by all hospitals within England. Whereas previously there was probably over 40 different kind of scoring systems used within hospital trusts, which meant that medical staff on rotation had to learn a new scoring system every time they moved, and there would be no big bits of evidence that could be used for research when all patients are being scored differently. So it is now mandated that all trusts use News 2, so we are now compliant with that as of December, and then there were some changes when we implemented News 2. So the nursing staff will enter the observations using the iPad, and the iPad will then calculate a score and give you a message at the end of that to tell you what you need to do about that score. So it's all very well completing the observations fully, The most important bit really about news is that you do something about the score that you have, and we don't just use it as a way of recording. We need to react to what we do. One of the mantras that came out with News 2 was a way of thinking about sepsis slightly differently to try and simplify that. So any patient now with a news score of 5 or more, we should automatically think, is this sepsis? Do they have evidence of infection? And if the news score is 5 and they have evidence of infection, we should complete the sepsis screening tool and call the appropriate people to come and start instituting the sepsis 6 management. News 2 also has a scale 2 for saturations, and this is for patients very specifically with hypercapnic respiratory failure, so that's COPD patients who retain carbon dioxide and have that documented. It shouldn't be used for other patients where we're trying to run them on lower oxygen saturation levels. If there's no evidence of CO2 retention, they should be on scale 1. From a safety point of view, we want a registrar or above to make that prescription for scale 2, and it needs to be documented in the notes. And then there are senior level nurses on the ward that can select scale 2 from within the News 2 software. It also comes up as a little flag on the EOBS that we can see on the screen which patients have been put on scale 2. The other change with News 2 was the AVPU score scale changed to ACVAPU, which is a lot harder to say, and that C stands for new confusion. So if a patient becomes newly or acutely confused, then they will get a score of 3 to add up to their overall news score. When new confusion is a bit of remains new is a bit of a question, and at the moment what we're saying as an organisation is once we've recognised and treated the cause of this new confusion, we can then start scoring the patient as alert again. So the News 2 scoring system, as you see it there, you can see what the difference between scale 1 and scale 2, whereas previously a COPD patient with saturations that we'd normally be happy with at 89% would have scored 3, they would now score 0, so it makes their score much more appropriate to them. We continue to score patients 2 points for being on oxygen, even if that is long term, and the rest of the scores haven't adjusted at all. What has changed, however, is what we do about the score and the trigger, as I mentioned earlier. So we've moved from a trigger score of 9 to a trigger score of 7 for initiating a news call. There is a whole teaching education package on the Royal College of Physicians site, and this is an example of one of the scenarios. So we have a patient admitted to the emergency department, and these are the observations that that patient presents with. When you calculate their news score on the basis of that, that will give you a news score of 6. The advantage of the whole of the NHS using this means that when the patient is seen at home by the GPs are also using News 2. So this patient might have had a news score of 4 when the GP assessed them. Paramedics then collect that patient and bring them into hospital, and they might have scored them as a news of 5 en route to hospital. They now arrived in the emergency department and have a score of 6. And we know that everyone is using exactly the same tool. We can see that the trend is this patient is deteriorating. And equally, we can see improvements when scores get better. So this patient on our graded response would be classed as high risk. So if a patient has a score of 5 or 6, they're in the high risk category, which means they should have a medical review or an outreach review if this is out of hours. And this should happen within 30 minutes. You might want to repeat their observations more frequently in that time, certainly if you're concerned about them. And if they've actively got chest pain and look very acutely unwell, you may want to escalate them to critical risk even though their score is 5. So we can put out a news call or a medical emergency call to any patient we have concern about, regardless of what their news score is. This escalation is the minimum requirement. Unless they have a treatment escalation plan documenting that they are not for news, or there's very clearly documented set different parameters for this patient, we should be adhering to this graded response. This slide is just showing us our audit that we perform annually, and what we can see where a vital pack was implemented back in 2015, we have seen a significant improvement in patients being escalated because that escalation message pops up at the end of each set of observations. And this again is really positive feedback for you guys on the wards. If we're not escalating a patient, it's really important that you document in your nursing all the medical notes as to why we've made a decision not to escalate. For example, Bob with COPD has just walked out to the toilet, he's come back, sat in his chair, you've done his set of observations, he's really short of breath because he's just worked a bit hard and his sats might have dropped a little bit. And given 10 minutes time, Bob will settle down and his news score will drop. That's a reasonable reason not to put out a news call. However, if they're lying in bed, nothing's changed, their news has gone from 0 to 7, then this patient needs to be escalated and they need to follow that protocol unless stated otherwise. So we've had a 90% compliance with those patients with high or critical scores having evidence of escalation or appropriate documentation that they were not for escalation in the first place. And that's amazing, and we need to maintain that standard.
Hi, I'm Dave. I'm one of the resuscitation officers, and I'm going to be carrying on from Pat's very good lecture. We're just going to talk about the A to E approach. The A to E approach is extremely important. It's the same assessment that's carried out on every patient, regardless of what's wrong with them within the hospital. And regardless of whether you're a support worker or whether you are a consultant, it's the same assessment. The only difference is what you can do within each area. So the most important thing to remember is that the idea of the A to E assessment is that actually we're trying to identify the thing that's potentially going to kill you first, the most serious injury or disease that you've got that we need to treat. And that's a principle at all times. Once we find something wrong with you, we don't move on until we've actually treated it. So the A to E approach is basically based around airway, breathing, circulation, disability and exposure. On the airway part of it, essentially what we need to know is the airway obstructed, is it patent, or is it at risk? So have we got a patient whose conscious levels reducing, or say for example a hypo patient who may reduce their conscious level, their airway may be fine initially but then become at risk. In breathing, we need to know whether it's effective. Are we managing to get oxygen from the outside to the inside of the body, and then that's circulating around the body? So regardless of respiratory rate, it may well be somebody can have a normal respiratory rate but actually not be effectively breathing. So we need to assess their rate, we need to look at the depth of breathing, we need to look at things like oxygen saturations to see if it has been effective. Circulation, we need to know that's adequate for tissue perfusion. Is the brain and the major organs being perfused properly? And we're going to do this by doing something we call the circle of circulation, which we'll cover when we do our patient assessment. On disability, it's really just a quick neurological check. So we're going to look at a patient's conscious level using the ACFA scale, which Pat talked about. We're going to check the patient's blood sugar. All patients, regardless of whether you think they're diabetic or not, should have their blood sugar taken. And then we're going to check pupillary response, just to see how fast they're reacting, whether they're reacting at the same size, so we can have an idea about what's going on within the brain. And then finally we're going to do exposure. So we're going to check our patient from head to toe, front and back, to ensure that we can find any deformity, bruising. The patient may have chest drains in that we're not sure about, or surgical drains that we've not seen. But the idea is to do a full head to toe examination to make sure we haven't missed anything and we find anything new, such as rashes. This part will also include looking at things like the patient's medical notes, their computer record. We check the patient's blood sugar. All patients, regardless of whether you think they're diabetic or not, should have their blood sugar taken. And then we're going to check pupillary response, just to see how fast they're reacting, whether they're reacting at the same size, so we can have an idea about what's going on within the brain. And then finally we're going to do exposure. So we're going to check our patient from head to toe, front and back, to ensure that we can find any deformity, bruising. The patient may have chest drains in that we're not sure about, or surgical drains that we've not seen. But the idea is to do a full head to toe examination to make sure we haven't missed anything and we find anything new, such as rashes. This part will also include looking at things like the patient's medical notes, their computer records, to see if there's anything in there that could give us an idea about what's happening to the patient. Okay, I'm now going to carry out an A to E assessment on Ingrid. I can hear some snoring. Hello, Ingrid, you alright there? You alright there? How are you feeling?
Where am I? Oh, I don't know.
Okay, you're just on the ward, so I'm happy you've got an airway because you're talking to me and I know that you're breathing. So I'm just going to go on to a breathing check now. So I'm just going to count your respiratory rate and just have a look at the depth. I'm going to do that over a minute. Okay, and you've got a rate of about 20. I'm now just going to check expansion. Okay, and that's fine as well, that's all normal. Let's get some oxygen saturations. See what they're doing. I'm going to pop this on your finger. Okay. So I'll just wait for that to come up, but I'm happy with the breathing. Normal rate, depth and rhythm, good chest expansion. We just need to know what SATs are, no cyanosis. Okay, so SATs are 96, so I'm not going to put any oxygen on it. Happy with breathing. So, Ingrid, I'm just going to check your circulation now, okay? I'm just going to take your pulse. Okay, so I'm just checking for rate and regularity, how strong it is. Do that over a minute, okay, and that confirms what the machine says, around about 63. Skin feels nice and warm, so obviously we're checking there for temperature and whether they're warm, dry, cold or sweaty, whatever. Moving up the arm, just checking for any IV access. We haven't got any IV access at the moment, so I might consider that. I'm just going to take your blood pressure, Ingrid. Okay. Do you know what your normal blood pressure is? Okay. I can look at your notes for that, that's fine. Okay, while that cuff's going up, I can do your temperature. Okay, that's fine at 37.2. And also I'm going to do a capillary refill time, so I'm just going to press on your chest for 5 seconds. 5, 1, 2, and it's come back up in 2 seconds, so that's normal. Anything over 2 would be show that there's some sort of compromise there. Do an ECG. If she's become acutely unwell, then yeah, get a 12-lead ECG organised. Systolic 115 over 80, so that's fine, that is normal for her. So circulation wise I'm happy. I think we'll organise to get a cannula in, get some bloods taken off. We don't need to give any fluids at the moment because her blood pressure is fine. Moving on to disability, so I'm going to assess the conscious state. So hello, you're right there?
Oh, yeah.
Okay, so you're responding to voice.
Oh, yeah.
Okay.
Where's George?
Where's George?
Where's George?
He's at home. We'll sort that out for you. The other thing I'm going to check is pupillary response. I'm just going to shine a light into your eye, okay, just to see what's going on. Okay. Okay, they look fine, normal size, normal reaction, normal sort of shape. Ingrid, I just need to give you a little check all over to make sure.
Did you get George?
Get George, we'll sort that out for you. So we now need to go on to exposure. So looking where I am now, have you got any pain anywhere?
Oh,
no. No? Okay, just have to feel down, there's nothing unusual there. Having a look at a calf, so a calf's at normal size. Is that painful at all?
Oh, no.
No? There's no heat and they're normal. Moving up, I'm just going to have a look to see if there's anything under there, and obviously keep maintaining dignity. If you're trained to do it, you can also examine the abdomen at this point. But actually I can't find anything wrong with Ingrid apart from the fact she's only responding to voice. So if she's only responding to voice, that will give her a new score of 3. But actually I'm still quite concerned about her because this is fairly new. So I think what I'll do is contact the outreach practitioners.
Hello, you calling outreach?
Hi there, yeah, it's Dave from the Resus team.
Oh hi, it's Pat, I'm on outreach today.
Hi, I'm up on B4. bed space 13, with a patient Ingrid. She was brought into hospital with acute abdominal pain and was just being watched by the surgeons. I've gone up to her today and she only seems to be responding to voice, which is a deterioration in her condition. I've done an assessment on her. Her airway is patent, although she's only responding to voice. She does still maintain it when she needs to. Her respiratory rate is around about 20. She's got good air entry, good chest expansion, so that's effective. The SATs at the moment are 94, but that's normal for her. Circulation-wise...
Is she on any oxygen to get those saturations?
No, she isn't, no.
She's 94 on room air?
94 on room air, yeah. The circulation-wise, she's got a nice, strong radial pulse, which is going around about sort of low 60s at the moment. At the moment, it's 63. I've got a cannula in. I've took her the normal bloods, FBCs, Usinines. There's no evidence of infection, so I haven't done anything with regard to sepsis. I've also took a venous blood gas as well. Her blood pressure is 115/80, which is normal for her. Her temperature is 37.2. She's got a normal capillary refill time of less than 2 seconds. I've looked at her chart and the urine output is normal. There's no deterioration in that. So I'm happy with her circulation. I don't think we need to give her any fluids. Disability-wise, normal pupil response. Like I say, she's only responding to voice. The venous blood gas came back and showed she had a blood sugar of 5.6, so that was all fine. And then on exposure, I've found nothing abnormal to detect. I've not found any swelling in the calves, any wounds, deformities or anything like that on her. And I'm just concerned, although she's got a new score of 3 because of her only responding to voice, I'm obviously concerned that she could deteriorate and become worse, and I'm not sure why she's deteriorated.
Okay, yeah, that sounds unusual. So does she make sense when you talk to her? Is she alert when you wake her up?
Yeah, she is alert. When I wake her up, she does open her eyes to me, she does talk to me.
She's not complaining of pain anyway? You said she came in with abdominal pain.
No, I asked her if she was complaining of pain, she said she wasn't.
And has she had any recent analgesia that might account for her drowsiness?
The staff nurse said she'd had 5 milligrams about 2 hours ago.
5 milligrams of
morphine, sorry.
Morphine, okay.
But she was fine after that.
Right, well I'll have a quick look on EPMA and just see how much she's had over the last period. Her pupil size you said was normal though?
Yeah, pupil size was normal and reacted normally as well.
Okay, so if we can just check out on her drug charts, make sure she hasn't had anything else on top of that. We'll come up and review her in a few minutes.
Okay.
In the meantime, if you've got any concerns, please do put out a news call.
Okay, thank you.
All right.
Okay.
Bye.
Bye. We've just got some help coming for you, Ingrid.
Oh, thank you.
Okay. So you're just going to list her A to E approach. So how I felt her airway was, which I felt her airway was at risk, but she was maintaining it. Her breathing, there wasn't any particular problems in breathing. Circulation, I'm going to tell the outreach practitioner exactly what I found in circulation, from pulse, blood pressure, how the patient felt to touch, urine output, and I'll make sure that there's an ECG been done before they get there. And then the recommendation, which is really important. So this is your opportunity to tell them how fast you need them to get there. So if you've got a patient you need to be seen straight away, that's exactly what you tell them. If that person then can't attend that patient, that's when we think about escalating further, so a news team or a med call, depending on what the situation is. But the idea is that actually you're telling that person how quickly you need that help, and you need to find out whether they can attend or not. When you do phone, we do have problems occasionally where people phone somebody to hand the patient over and don't necessarily have the right information. So please make sure that you've got the right information to hand over about the patient. So obviously your A to E assessment, so you've got all the observations, something about the background, and exactly what's happened. And make sure that if you've been told to phone someone, but you're actually the clinical person in charge of that patient, how fast you need that team. and that will be your SMAR approach. We're now going to move on to sepsis, which is quite a serious problem in hospital. Obviously, we have lots of patients come in with sepsis, but also patients develop sepsis while they're in hospital, things like hospital-acquired pneumonias. So it is quite a major thing to be looking for. We've looked at how the NEWS 2 system works, so anyone with a score over 5 should be getting assessed. The way we assess them is to use the sepsis screening tool. So this is the sepsis screening tool that we use for non-pregnant adults. The idea being that actually you go through this tick box approach, and basically it will give an assessment for you and tell you whether your patient is suffering from sepsis. If they're not suffering from sepsis, it also gives an indication as to what things you could do. So with regards to blood tests, with regards to treatment. If we do think our patient has got sepsis, then on the back of the page, it's got the Sepsis 6 pathway, which is really simple. It's a really effective way of treating sepsis. It can be done in the majority of clinical areas, and essentially we're going to give 3 things and take 3 things. We're going to give high flow oxygen, we're going to give fluids, and we're going to give antibiotics. The 3 things we're going to take are an arterial blood gas or a venous blood gas to find out what their lactate is. We're going to take some blood cultures to try and identify what the organism is, and we're also going to look at their urine output. So obviously some of these patients may not be on a fluid balance chart already, but if they aren't, we should start one at that point to try and monitor what the fluids are. If you work in other areas, we've got different charts that can be used for them. So we've got a maternity chart, we've got a neutropenic sepsis screening tool, and we've got a pediatric sepsis screening tool. So regardless of where you work, there will be some screening tool that you can use. So wherever you are working, please make sure you're familiar with it and you know how to use it. It has been proven to be a really effective way of identifying these patients, and it takes less than a minute to do in reality. We'll now move on to anaphylaxis. Obviously in hospital we still get people allergic to different things, and also we administer lots and lots of medications to patients, and they may not be aware that they're allergic to them. So occasionally we do get patients who have a reaction to it. When we talk about anaphylaxis, we're talking about that life-threatening response to whatever they've had a reaction to. So we're not talking about somebody who gets a bit of a rash or feels a bit itchy. We're talking about that systemic life-threatening problem. So if we use our A to E approach, we can see what the sort of things we're looking for. So we're going to look for swelling. So we're going to look for swelling around the lips and the mouth, and also some facial swelling as well. Obviously, make sure you get them to open their mouth, look at their tongue, see if there's any swelling inside the mouth as well as outside. Listen to their voice. Sometimes their voice will start to change as the airway swells up, so that might be fairly noticeable. They may start to develop a wheeze. As their airways start to close over, they'll sort of develop breathing problems, so they'll develop a wheeze. They'll start to look like they're starting to struggle to breathe as well. And then ultimately they'll develop stridor, which is a sort of a sound while they're trying to breathe. We know at this point that their airway is massively closed off, so it is a medical emergency. It may well be, if they've been doing that for a prolonged period of time, actually those sounds die off. You need to ensure that actually that's because you've treated them well and not because they've become exhausted at that point. We then move on to breathing. So they're going to look like they're having difficulty breathing. If their airway's swelling up, they're struggling harder to breathe. So you'll start to see them using their accessory muscles, so the neck muscles and the chest muscles, to try and breathe properly. They may well be trying to sit up and put themselves in a better position. If they are doing that, as long as they're safe, let them do that. Let them sit up and let them get themselves in a position they feel comfortable in. Their respiratory rate's going to increase. The amount of oxygen they're taking into their body is being reduced, so they're trying to compensate for that. so their actual respiratory rate will increase quite dramatically. Their oxygen saturations obviously will start to drop if they're not getting oxygen in. Obviously with these, if you do notice any airway breathing problems, we want you to put on high flow oxygen straight away. If we look at circulation, their blood pressure is going to start to drop. So as the blood vessels vasodilate and fluid leaks out into the tissues as well, the blood pressure is going to drop. So alongside that, they're going to become quite sweaty and shut down. The heart rate's going to increase, and they may well start to feel sort of dizzy, faint. They may become agitated because obviously their brain's not being perfused properly. So there we're going to look at getting a line in, we're going to look at getting fluids in. If they're able to, you can lie them down and put their feet in the air. That will help them with their blood pressure. When we come to disability, obviously their conscious level will change. So as they get less and less oxygen in, as their brain's not being perfused properly, then their conscious level will sort of start to go down. So they may start off alert, but then end up to the point where they're unresponsive. And then on exposure, you may see, and depending on the patient, some it comes fairly early, some it's a bit later, you may see just a widespread raised red rash over their body. Importantly for anaphylaxis, we need to know when to give the adrenaline. So if at any point we find something that is life-threatening, that is when we give the adrenaline. So if we have a patient who's got a swollen airway and is not breathing properly, that's when we give the adrenaline. We don't move on to the next stage. If we go to breathing and they are having real difficulties in breathing and a fast respiratory rate, then we may give it then. If we have a shocked patient, so we find in circulation that they're shocked, we may give it at that point. The key thing is when you identify something life-threatening, that's when it should be administered. You don't need to complete the whole A2E assessment before you give the adrenaline. We follow the Resuscitation Council guidelines for anaphylaxis, and that's the algorithm there. And it's quite a good algorithm. It tells you exactly what to look for life-threatening problems in airway, breathing and circulation. So just make sure you're familiar with them. For all adults, we give 0.5 milligrams of adrenaline, 1 in 1,000, and that's always given intramuscularly. It is not to be given intravenously. So any drugs during anaphylaxis with regards to adrenaline should be given intramuscularly. If you work with paediatrics, then obviously essentially the algorithm's the same, it's just a change in drug dosages, so make sure you're familiar with those changes. The adrenaline we have available at the moment comes in ampules, so you'll get an ampule, a syringe and a needle in the blue crash box, which is in the bottom of the red emergency trolleys, and you basically draw up the full amount, the 1 ml, squirt out half of it, and then administer the other half into the patient's thigh. Some patients will come in with auto-injectors, so if they have got an auto-injector, they're fairly easy to use. Just remove the blue cap on the top, and then basically you just administer it into the thigh and hold it there for around about 3 to 5 seconds. Okay, now we're going to talk about choking. We do get patients who choke on the wards. Obviously we have patients who have difficulty in swallowing. We have patients who have reduced levels of consciousness and sort of obstruct on various different things. So we're just going to go through the algorithm on choking. The first thing we need to do is assess our patient, and that's really important. So we do a really simple check. We talk to them, we ask them, are they okay, are they choking? If somebody turns around and says, yes, I'm choking, clearly they're not choking, because we know by talking that their airway's patent, that they're getting oxygen into the lungs, they're breathing effectively. If we have a patient like that, then we just encourage them to sit forward and to cough if they've got an effective cough. So those patients are fairly easy to deal with, but just make sure you keep an eye on them, because if they have got something in their airway and they're coughing it up, we don't want them to obstruct and then nobody be around. our second group of patient are the ones that haven't got an effective cough and are obviously sort of choking. So the sort of things you will see is that they might be clawing at the throat or pointing at the throat. When you talk to them, they might just be silent because it's completely obstructed or not be able to get any words out. You're going to get facial changes, so the colour of their face is going to change. They're going to go all sorts of colours, or they'll get congested, they'll go red, blue, purple. And obviously look at the history as well. You know, most of these cases happen with somebody around, so somebody normally can tell you that they have been choking. So what I'm going to do is demonstrate what to do on John here. So basically John is our mannequin that we're going to use to sort of demonstrate the choking algorithm. Like I say, if I turn around to John and say, "You're right there, John, are you choking?" and he goes, "Yeah, I'm choking," he's not really choking. Lean him forward and encourage him to cough. If I look at the patients, they can't speak to me. I can see they've got changes in colour in their face, and also, you know, somebody's just said he was eating something and he's just started choking. Then I need to take some fairly effective action. So what I'm going to do is stand at the side of the patient, and I'm just going to let them rest on my arm and support them. In between the shoulder blades, with the heel of my hand, I'm going to give up to 5 back blows. Okay, so tell your patient what you're doing. I'm just going to hit you on the back, try and get this out. Once, see if it comes out. Twice, see if it comes out. 3, check again. 4, check again. 5, check again. If it does come out at any point during this, then obviously you can stop doing the back blows, and then we should carry out an A2E assessment on the patient to make sure that actually it hasn't affected them in any other way. If we're unlucky and it doesn't come out at that point, we then need to do abdominal thrusts. So this time we're going to stand behind the patient, and I'm basically just going to make a nice flat fist with my hand, and I'm going to place it between the umbilicus and the xiphisternum, so that soft part. So I'm going to reach around the patient and then bring my other arm around, and then I'm going to basically make a J motion, so I'm going to go in and up at the same time. Okay, so I'm just going to do an abdominal thrust. So we'll do 1, see if it's come out, 2, see if it's come out, 3, see if it's come out, see if it's come out, 4, see if it's come out. Obviously if it does come out, again, if the airways, we then carry out an A2E assessment to make sure our patient's okay. If it hasn't come out, we're then just going to alternate between 5 back blows and 5 abdominal thrusts. The patient's only going to be able to sustain not getting oxygen in for a short period of time. So we should be thinking about what happens if it's not going to come out. So if we're in an area where there's lots of things around, we should clear the area because our patient's going to have to go on the floor. If they do become unresponsive, then essentially we're going to do our basic life support, which we'll look at in a minute. The only difference will be is that when we actually do the head tilt chin lift and look in the airway, we're going to take a little bit longer just to check to see if there's anything there. If we try bagging the patient and the air's not going in, then you just check every 2 breaths to see if anything's shifted. The abdominal thrusts normally work pretty well. The idea of doing the CPR is to mimic those abdominal thrusts. It's not to keep the heart going. If the obstruction hasn't come out immediately, then please make sure you've called the adult medical emergency team. If you're outside the hospital, make sure you've called an ambulance straight away. There are a couple of groups that we're not going to do the abdominal thrusts on. Firstly, we're not going to do it on pregnant ladies. Apart from the actual logistical side of getting your arms around and doing an effective thrust, there's a chance we can damage the baby. So we don't want to do that. So no pregnant ladies. We're not going to do abdominal thrusts on anything under 1 year old. Most of their organs are actually in their abdomen, so we don't want to damage any of them. And we'll cover what to do with paediatrics later on. There are some situations as well, if you've got a patient who's absolutely huge and you can't get your arms around them, then obviously you can't do the abdominal thrust, you just need to continue doing back blows, and then if they become unresponsive, do chest compressions. The rest of the
Hello there, I'm Ingrid, I'm one of the resuscitation officers here. We're now going to look at early CPR to buy time. We're going to look at the second link in the chain of survival to demonstrate how important good quality chest compressions are, and we will be demonstrating that to you in one moment. We're also bringing in the current guidelines at the moment with the COVID-19 epidemic. Hello Fred, can you hear me? Can you hear me? Can I have some help in here please?
Ingrid, what's the matter?
Fred is in cardiac arrest, Pat. Can you put out an adult medical emergency call on 2222 to B4 room 6? Come back with a crash trolley and anybody else that will come.
Okay, we'll do. I'll be quick as I can. Right, Ingrid, the team are coming. I'm just getting my PPE on and I'll be in to take over from you.
Okay, Pat.
Just keep going if you're alright.
Right, I've just demonstrated to you what would happen in real time. Now I'm going to talk through each stage as we go. So the first thing that you need to do is to make sure that your area is safe, that there are no trip hazards, no hysterical relatives, no fluid you're going to slip on, and that you have your appropriate infection control outfit on. The next thing I want to do is to approach the patient and stimulate them. So I'm going to say, Fred, can you hear me? So I want to shake him. Fred, can you hear me? The next thing I'm going to do, because he hasn't responded to me, is shout for help. So really, really clearly, can I have some help in here, please? And push your button if you're on the ward. If nobody is coming, you must go and get help for this patient and not begin anything. So I'm called for help. The next thing I need to do is to assess the patient. And in our current COVID climate, I am not going to go near the airway at all. So I am going to, at arm's length, feel for a pulse, any normal signs of life, and I have 10 seconds to do that. My assessment now is because I had my surgical mask on, my visor, my gloves, and my apron that you would have in all areas, I can begin CPR. My help has now arrived.
Are you alright, Ingrid?
And I'm going to be very, very clear and state exactly which team I want and where. So Pat, could you put out an adult medical emergency call please on 2222 to ward B4, room 6, come back with the crash trolley and anybody else that will come.
I will do that.
Okay, so I've made very, very clear instruction there. I know help is now on its way. The next thing I'm going to do is to start my CPR. So I need to make sure that I'm at least mid-thigh above the patient. If they're on the floor, leave them on the floor. If they're in a chair, put them on the floor. If they're in their bed, then obviously you can leave them in their bed, pulling the CPR pressure relieving mattress cord if necessary, so you've got a nice firm surface. The next thing I need to make sure is that I put the heel of my hand in the correct position on the patient, which means mid-nipple line, lower third of the sternum. I'm going to use the heel of my hand. I'm placing my other hand how I feel comfortable. I'm locking my arms and I am going to start chest compressions. Now my compressions need to be 100 to 120 a minute. I'm going to press as hard as I can, which is 5 to 6 centimetres. When I press down, I need to make sure I recoil so the heart can refill again. Very important. And I am going to carry on doing this until my help arrives. Okay, so that's a demonstration of really, really good chest compressions. It's absolutely imperative. So it's 5 to 6 centimetres deep, as hard as you can push, ensuring that you have that recoil back off the chest so that the heart can refill. You're going to do 100 to 120 a minute. and you are going to carry on till your team arrive. You are not going to touch the airway at all in these current situations, but you must continue to do really high quality chest compressions. Right, what might make you stop your chest compressions? So, during a resuscitation attempt, to analyse the rhythm once the defib monitor is attached to the patient, you would need to stop while the rhythm is being analysed. And that's a really good time to actually swap over, because one round of CPR is a really good round, so continually swapping over to ensure that quality is high is absolutely imperative. You may stop if somebody finds a DNAR form that is pertinent to this patient, so you could stop, because don't forget, if you are not sure whether this patient is DNAR or not, you must start chest compressions and call for the team. You will stop when the team have decided that it's futile, and that will be a team decision, and you will all be asked what you think about that. You would also stop if you were on your own and absolutely exhausted or in danger. In course, if your patient shows signs of life, then you will go on to your ABCDE assessment. Thank you. As you can see, I have just demonstrated a COVID-19 negative or patient without any symptoms. So it's starting your chest compressions only. You're leaving a face mask on a patient if it's present on the patient, and that will protect you. The first team member in full PPE, as per Action Card 1, arrives, and you will hand over the chest compressions and then remove yourself from the room. Leave the area and don full PPE if required. So any doubt, confirmed or suspected COVID-19, you are only going to take the defibrillator into the room. You are not going to start chest compressions. So that needs to be passed to you in the room while an adult medical emergency call is going out as quickly as possible. If there is somebody around that is ILS or ALS trained, they are to don full PPE and go into the room where they can assess for shockable rhythm and start chest compressions. Leave the face mask on the patient again, and once the first responder arrives, they will have level 3 PPE on. Anaesthetics are to manage the airway and breathing, so nobody is to get a bag valve mask and start anything to do with the airway whatsoever. That will be they will be part of the team, and when they arrive, they will manage the airway completely. A really good point to make is if you are on a ward and working as a team, identify who is ILS and ALS trained at the beginning of a shift, so you know that they will be first responder and can have the defibrillator passed to them, the pads can go on, and a shot can go into the patient prior to the team arriving. That might negate all of the other interventions that we might need to do at that point. Early defibrillation, really important that if a patient is in a shockable rhythm, we get a shock in within 3 minutes. As you can see, all of our defib machines are used in this trust in automated mode. So if you are ILS or ALS trained, you can safely deliver a shock to the patient. The energy levels are 200 joules, 300 joules and 360. Compressions during charging, but in our COVID patients, or suspected COVID, you need to make sure that you're in level 3 PPE before compressions begin. Pad placement is really important, so make sure the patient is dry, make sure that they are shaved so that the pads can get a really good adherence to them, and as you can see, you can place the pads below the right clavicle, mid-axilla and sandwich. Alternatively, you can do anterior and posterior, or you can do lateral. This is our in-hospital algorithm, and as you can see, as Dave mentioned before, the ABCDE, when a patient is alive and going through that systematically, trying to reverse anything that is happening. Once a patient becomes unresponsive and there are no signs of life, we are going to go through our in-hospital algorithm for cardiac arrest and apply the pads, and then hand over to the team as they arrive. And they will come into the room and take over. Post-resuscitation care and documentation and communication. So our emergency record sheets are on the computer. They are on EPR, so they will be filled out by the team leader who will enter that in for our records and for audit. As you can see, there are 3 lots of chest compressions there. One shows chest compressions in the centre that were done by a Lucas machine in our ED department. It then shows a very weak chest compression, and then it shows a very frantic chest compression where the heart will not refill. So it's very, very important you remember to swap regularly so those compressions are of a really good quality. Our emergency trolleys. So we have our emergency trolleys, and really important, the daily checks that are done on our emergency trolleys is to ensure that our suctioning is working well, because most patients will have an event and it's not always conveniently by a bed. It could be in a corridor or by a toilet. So you want to have your full complement ready to go for that patient. So we're making sure that our suction is ready and works well. We make sure that our defib is checked regularly by self-test every day and signed for. We want to make sure that we have a full oxygen bottle and that it's in date, and that we have gloves and other equipment on our crash trolley. Our monthly checks are to open up the crash trolley and make sure that every drawer is checked. Make sure that everything is in date and that it's going to be in date by the end of the month. If it isn't, send it to a department where they can use it, so we save resources. But that must be in fully functioning order when we present that for a cardiac arrest. Our top-up cupboard is on the lower ground floor. Porter's Lodge will have the key on level -1, and there is a grey cupboard where you can replenish your crash trolley as you wish. Audit results, we audit the crash trolleys regularly within the trust to make sure that they are up to standard. So please ensure that your crash trolley is up to standard, in date and ready to go. Remote equipment, we have equipment in the main multi-storey car park. So if somebody had a cardiac arrest on level G, there is a defib machine on level C. There is also a red phone if your mobile phone wasn't working to call for help. We also have a defib machine by the main reception on the wall. So if there was a cardiac arrest within that area, there is a defib machine that you can grab very, very quickly in an emergency.
Okay, so just to talk a little bit now about allowing a natural death and do not attempt cardiopulmonary resuscitation. You should know by now that we have a pan-Dorset policy, so all of our hospitals in the region, care homes, GPs, etc. all use the same policy and same form. The only difference here at Poole Hospital is our form is created electronically, where elsewhere the form is still handwritten. So we will accept a resuscitation status decision that's brought in with a patient from the community, but there are still some checking procedures that we have to do to ensure that that decision is relevant for the patient at that time. So it's quite easy when we make a decision during the patient's admission. So if we've made a decision, this patient's status is as such that they would not survive a cardiac arrest, it's usually a team decision that resuscitation would not be appropriate for them. It's a consultant-led decision, but we allow the registrars to make that decision in the out-of-hours period, but consultants should validate that within 48 hours. The form is created on EPR, and when the doctors create the form, they have the options of making the decision indefinite, which means this will go home with the patient. They can put a review date on it, so if this patient is acutely unwell, but we think they may or may not get better. The problem with review dates is they very rarely get reviewed, so if you see a form with a review date on it, please make sure the team update that. Or you can make it cancel on discharge. So this would be the patient's decision would no longer be valid at the point they go home, in which case we need to do no more. So if they come into hospital with a form, and it's a paper form a GP has written, we'd still require the doctors to put that onto EPR, and all they would need to document was this is a GP decision, it's already been made by a consultant, so they're just transferring that information onto our system so that we have a record of that in the future. It would then be printed out on red bordered paper and put in the front of the patient's medical notes, and we therefore know that decision has been reviewed on admission. At the point of discharge, if the patient has an indefinite decision that has been signed by a consultant, then that decision should go home with them. The patient should take the red bordered form from the front of their notes. We shouldn't photocopy it, we shouldn't print out other versions. That original copy is the patient's copy to take home with them. The form should be checked though, because we do still see on many forms in the communication section that the communication is to still happen, and there's no evidence that the patient is therefore aware of this decision having been made, and that's not very good practice. So the recommendation legally is that patients should be fully aware that they have a resuscitation status decision, and they should be involved in that conversation. They don't necessarily get a choice on being for resuscitation, but they certainly have a choice in being not for resuscitation. But we need to have those conversations in a timely fashion and by somebody that's able to hold that conversation appropriately. So patients must be aware that they have a DNACPR decision, and if they have dementia or are not able to understand that decision, then at least they're next of kin or a carer who is going to be going home with them. At the point of discharge, when the doctors complete the inpatient discharge summary, they will be asked if this patient has a DNACPR form in their notes. If the answer is yes, they will then be asked, has a consultant signed this off and agreed that it is indefinite? If they answer yes to that, there is an automatic process set into place. The GP will be informed automatically via the IDS, and an email gets sent to South West Ambulance that's fired off automatically every 2 hours from the trust, and they are then made aware of those patients that are discharged home with an indefinite DNACPR decision. This enables them to then have a flag on their system, so when a call goes out to that address, they can go into our EPR, they can see the form, print out a copy, send it straight to the paramedic via their electronic system, whichever they need to do. So even if the form isn't present in the house, the paramedics will have had sight of it and can prevent them from doing inappropriate CPR in end-of-life situations. In an ideal world, the patient should always have the form with them. So if they have a DNACPR form in the community, it should come with them to hospital and wherever else they may go. Decisions can be cancelled, so nothing is permanent. So if a decision's been made to be not for resuscitation, even if it has been listed as indefinite, it can be reversed for whatever reason, and the medics would go onto EPR and make that form cancelled. The one that's therefore in the front of the patient's notes needs to be ripped up and put into confidential waste. And then it becomes clear on EPR that that form is a cancelled decision. Any patient that has a form written, we can see there is an orange folder that appears on the EPR tree. So that includes treatment escalation plans. So if they've had a DNACPR form at any time in the past, that orange folder will now be visible. But it's really important to open that orange folder and see the contents of what's in there, because cancelled forms will also still live in an orange folder. There is a patient information leaflet which we can give to reinforce the conversations that we have. These are available to be ordered via the printed stationery, and they are very useful for explaining what resuscitation is. We often find that patients that insist on being for resuscitation really don't understand what that means. They think that they will have their life prolonged and they will have good quality. And what we're saying when we make somebody not for resuscitation is their quality of life is either not going to be maintained or they are very unlikely to survive that cardiac arrest. So this information leaflet will give some idea as to what resuscitation actually means to them.
So we're now going to cover paediatric basic life support. This isn't a full paediatric basic life support course. If you are working regularly with children and you need to attend a paediatric ILS course or paediatric BLS course, this is just an overview to highlight the differences between adults and children. Firstly, the majority of cardiac arrests with children are normally due to the fact that they're not getting enough oxygen in the body, and there's some reason that's been interrupted. So we're going to go through how we do basic life support and then just very quickly look at choking. So we classify children in different things. So anyone under 1 is classed as an infant, anyone above 1 is classed as a child. If you're not sure when their date of birth was, then just use a bit of common sense. If you look at them and think they look like a baby, treat them as a baby. If you look at them and think actually they're a bit older, then treat them as a child. So first of all, the differences in paediatric basic life support. We still do our SSS approach of making sure it's safe for us to actually get there to do something, because the reason that child might be collapsed in that area is because there's a problem in that area. We still shake them, we still try and stimulate them. So with the baby, I'm going to hold the head still, and I can sort of tap them, I can tap the bottom of the feet. If they've got some hair, you can pull the hair as well. But basically something just to try and sort of make them respond to you. If there is no response, The difference now between this and adult basic life support is that I'm going to assess the airway. So the airway, unlike an adult, shouldn't be tilted back. They should be in a neutral position, basically looking directly up into the sky. Support their chin with your finger on the bony part, so you're not pressing the bottom of the mouth in. And then we do our look, listen, feel the same way we would with an adult. So we're trying to feel any breath on our face, hear any noises, and look at the chest to look for what we think is normal chest movements. And we can do that for up to 10 seconds. If there is no signs of life, then at this point we're going to give 5 rescue breaths. So with a baby, we need to make sure we cover their mouth and their nose. When we blow in, we give 5 short breaths, but only until the chest rises. Please don't try and empty your entire lung volume into a small baby. After we've given 5 rescue breaths, we then reassess the ABC. If that's been successful, then we can carry on and do our A2E approach on them. If it's not, this is when we're going to carry out chest compressions. So locations for a baby to do chest compressions is between the nipples. You can hold them in your arm if you're sort of moving anywhere, 2 fingers, and then we're going to do 30 compressions. Okay, 1, 10, up to 30, and then we do 2 breaths. So the same as the adult basic life support. Once we've done that, 30 compressions to 2 breaths. If we have a baby that's choking, then again we can do back blows, so use a bit of gravity, hold them in your arm or hold them down somehow and just hit them between the shoulder blades. Remember, it's a baby, so you're not going to use the same force as you would on an adult. So again, 1, 2, 3, 4, 5. If that doesn't work, remember we said we don't do abdominal thrusts on anyone under 1, so we're going to do chest thrusts. So exactly the same place you would have done chest compressions for CPR between the nipples, and it's a really quick push in and sort of upwards at the same time. So we can do up to 5 of them. 1, 2, 3, 4, 5. And again, we just continue doing back blows and then chest thrusts. But if it's a paediatric case, obviously in hospital, make sure you've called the paediatric medical emergency team. If it's outside hospital, just make sure you've got an ambulance coming straight away, because they won't tolerate having no oxygen for very long. If it's a child, so over 1, it is fairly much the same as an adult. So the only difference is really when we do the chest compressions, we do our SSS, ABC. If they're not breathing, no signs of life, we give 5 rescue breaths and then reassess again. And then this time if we do chest compressions, depending on the size of the child, will depend on whether you use 1 hand or 2 hands, and the size of yourself as well. So again, with this child between the nipples on the breastbone, I'm going to use 1 hand, and we want to compress about 1/3 of the chest. So 1 and 2. So I'm going to do up to 30 of them. Once I've done 30 compressions, then we can do 2 breaths. So in the current COVID situation with children, we just carry on and do everything as normal. The difference this time is I need to pinch the nose and cover the mouth and blow in, again, just till the chest rises. Choking wise, we can do back blows and we can do abdominal thrusts, but remember, what we don't want is children being lifted off the floor and people attempting abdominal thrusts like that. You need to get down to their level, so you may need to sit or kneel down on the floor. If they're old enough, you can have them over your knee to assist you to do the back blows. But again, make sure that you have got help coming straight away. With regards to CPR on paediatrics, if you haven't got help coming, then we do CPR for 1 minute and then we call for help. But remember, use your mobile phones, put them on speaker. You can carry on doing resuscitation while you're talking to the ambulance service. But if that's not possible, do 1 minute of resuscitation and then go make sure you call for help. Okay, so you've come to the end of your online learning for resuscitation, and so just to summarise, it's absolutely essential that we do that first check, that we actually recognise our patients are sick, we use the tools that are in place, things like the news scoring system, and actually we call the right people in to deal with that patient, so utilising the right teams, the news teams and the med teams. So making sure you get those people in early. Nobody's going to get in trouble for calling the team in early. That's exactly what we want, and that's why our figures are going in the right direction. Secondly, CPR. CPR is absolutely essential, but good quality CPR is what we're looking for. So please make sure that you're doing really good quality CPR, you've got the right depth, the right rates, the right compression. If you see your colleagues flagging they're getting tired or they're not doing it properly, please tell them or swap around. But what we want is that really effective chest compressions to try and perfuse the brain and the other organs. Early defibrillation, if you're trained to do it, then actually please do it. If you've got the right qualifications and you're allowed to do it, then do it. And you can do that before the resuscitation team arrive. And if your patient's in a shockable rhythm, actually that might be the thing that brings them out of it. But also, if you're not trained to do it, make sure that equipment is in the room with the patient and ready for us to use when we get there. Post-resuscitation care is something that as a team we'll take care of between ourselves and intensive care and outreach, and make sure that actually that patient who has been resuscitated is being looked after properly. Resuscitation is only a temporising measure, if you like. You know, we've got them back, we've got retained and spontaneous circulation, but there's still clearly a big insult going on that we need to deal with, and there'll be people around that can help you deal with that for that patient. And make sure you enjoy coming to your half-hour session. And we will teach you your practice.